Hello everyone, welcome to the next review by Nurture Oncology. This review is based on an article by Leovatana et al. Titled Systemic Treatment for Advanced Pancreatic Cancer. So, in the introduction itself, they've emphasized on the importance of pancreatic cancer being a leading cause of cancer-related mortality. And over the past several decades, pancreatic cancer incidence has rise as well as the detection rates and the precursor lesions that preceding it are increasing. This is an overview of the epidemiology. So, as we can see, the number of pancreatic cancer cases that are listed over here, and modifiable risk factors include obesity, type 2 diabetes, smoking cigarettes as well. Here, genetic risk factors are cited to be, are cited as a risk factor for about 5 to 10 percentage of all pancreatic malignancies. And they've mentioned a few syndromes too, as well as the genetic basis for the same. So, clinical presentation, it shows that nausea, bloating, stomach fullness, changes in stool consistency are some of the signs and symptoms. Stomach discomfort, abnormal liver function test, jaundice. Other clinical symptoms are occur as well. Now, let's go to the actual part of the article. Advanced pancreatic cancer treatments. Here we have chemotherapy, targeted therapy, immunotherapy, and cancer vaccines. These are the four main portions which we are going to be covering today. So chemotherapy, gemcitabine is like used to be the standard treatment, and the survival benefit is about 5.6 months median. Folfirinox is a combination of folinic acid, fluorouracil, irinotecan, and oxaliplatin, and it increases the median survival to 11.1 months, but it comes with more side effects. It's recommended for patients with a good performance status who can tolerate increased toxicity. Now, nab-paclitaxel with gemcitabine. It's another combination therapy offering improved survival of about 8.5 months and progression-free survival too compared to gemcitabine alone. It has a higher 1 and 2 year survival rate but increase the risk of nerve problems and bone marrow suppression. So the best option depends on a patient's overall health and the ability to tolerate side effects. Younger and fitter patients are most likely to benefit from folfirinox. And here they've given the location of tumor within the pancreas that affects the patient's presentation depending on the location. If it's in the head and neck, it can cause biliary blockage and weight loss as well as jaundice. The pancreatic body, it might cause epigastric pain, discomfort, and in the tail, again, since it's epigastric or back pain. And next, let's go to the targeted therapy. Unlike traditional chemo, which targets all rapidly dividing cells, here target therapy uses specific drugs to attack cancer cells by binding to receptors or proteins on the cancer cells. Here they've talked about this like in general, and it can also inhibit enzymes and growth factors which are crucial for cancer growth. So the benefits of targeted therapy includes it may lead to fewer side effects compared to chemotherapy. Example, reduced hair loss. And it offers more precise targeting of cancer cells. Types of targeted therapy. Small molecular inhibitors. Small molecule inhibitors are the first category. These drugs enter cells and target specified molecules involved in cancer development. This is the basic principle. And examples include proteasome inhibitors, VEGF inhibitors, and histone deacetylase inhibitors. Proteasome inhibitors block protein degradation, such as bortezomib is a drug, which is a proteasome inhibitor, and induce cancer cell death by causing the accumulation of, like, you can say bad proteins as such. And then VEGF inhibitors block the formation of new blood vessels that feeds tumors because, as we all know, tumors have increased vascularity, and then if we block the process of formation of blood vessels, we'll be able to seize the tumor growth. Sorafenib and sunitinib are two drugs. And then histone deacetylase inhibitors disrupt the growth of cancer cells. Example is belinostat. And all these three have limited efficacy while limited benefit, while like histone deacetylase inhibitors have not been yet tested in our series. Targeted therapy is one branch which is believed to replace conventional chemotherapy. It has specificity and potentially fewer side effects. Now let's go to immunotherapy. Immunotherapy approach aims to leverage the immune system to recognize and attack cancer cells. That's basically it is leveraging the patient's own immune system to attack cancer cells and uses various strategies like cancer vaccines to enhance antigen presentation, immune checkpoint inhibitors to block mechanisms that suppress immune responses, and adaptive T cell therapy with modified T cells to target cancer cells. Now, challenges for pancreatic cancer includes the fact that pancreatic tumor microenvironment suppresses both natural and induced anti-tumor immunity. Let's go to the immune checkpoint inhibitors now. Immune checkpoint inhibitors target proteins that regulate the immune response. Two main checkpoint targets are PD-1 programmed death 1 receptor and cytotoxic T lymphocyte associated antigen 4 CTLA4 receptors. So here I'll give you examples of PD-1. Anti-PD-1 is nivolumab, pembrolizumab, and durvalumab, while ipilimumab is an anti-CTLA4. Limited benefit has been shown in studies, and these drugs are still under consideration or study. And there is another category called CAR T cell therapy. CAR T cell, this chimeric antigen receptor T cell. This is basically using genetically modified T cells to target specific antigens on cancer cells. Mesothelin is a promising target antigen for pancreatic cancer, and early phase trials show potential efficacy and safety requiring further investigation. So, this is basically CAR T cell in short. And in the article, they have given the survival rates and the median survival as reported by the studies. Now let's go to cancer vaccines. Types of vaccines include autologous and allogenic vaccines. Autologous is made from a patient's own tumor cells or antigens, while allogenic are made from another person. Studied vaccines include whole cell vaccine. GVAX is the most studied. The others are CRS-207 and algin pantocell lel. GVAX showed promise in some trials, but there is no significant improvement in survival rates overall. CRS-207 and algin pantocell L results are mixed in different studies. Peptide vaccines target specific antigens like KRAS, MUC1, etc. At the one antigens that are targeted. KRAS peptide vaccine showed some ability to induce immune response but limited impact on survival in large trials. Vaccines targeting MUC1, Gaussian, and telomerase haven't shown significant improvement in survival as such. Dendritic cell vaccines are another category. Dendritic cells loaded with tumor antigens to activate T cells forms the basic principle. And early trials of dendritic cell vaccines used alone or with chemotherapy showed some promise, but they need further investigation as of now. And combining these DC vaccines with other therapies like S1 or CAR T cells is currently being explored. So, therapeutic cancer vaccines are still under development for pancreatic cancer. While some early trials showed positive results, larger studies haven't shown significant improvement in survival rates yet. More research is needed in this area to identify the most effective vaccine strategy combinations for pancreatic cancer treatment. Coming to the conclusion part, the aggressiveness of pancreatic cancer and lateness of its discovery make it very challenging to cure. The majority of patients have advanced stages, which makes therapy difficult. Although advanced pancreatic cancer can be treated with chemotherapy, radiation therapy, and surgery, there is no definite treatment. And in general, chemotherapy leads to several side effects as well. Hence, this article stresses upon the fact that there is a need for innovative treatment approaches for pancreatic cancer, such as cancer vaccines, which I spoke about, in addition to the conventional targeted medicines and immunotherapies that have been investigated for years as such. Since the death rate and associated with pancreatic cancer is high, as well as the overall survival becoming low and incidence rates increasing, we are, being future researchers, we are supposed to contribute to this area as it is likely to be helpful in improving the patient's lives as well as the medical research society, as well as contributing to the medical research society as such. Thank you everyone for your patient listening. See you next.